Okay, let's dive in. We've got this stack of material here, all focused on a condition that, well, it touches millions of lives globally. Type 2 diabetes.
Mm.
It's a term thrown around constantly, but when you really dig into it, what is type 2 diabetes at its core? And why does it remain such a formidable health challenge worldwide?
That's exactly where these sources want to take us. We're looking at papers and data covering, everything from the fundamental definition and root causes
Right.
through how it's diagnosed and treated, and critically, what it means for long-term health, those potential complications.
Our goal for this deep dive is really to cut through the noise. We want to extract the absolute essential insights, maybe uncover a few surprising facts from the research,
Yeah.
and leave you feeling genuinely informed about this complex condition without needing a medical degree.
Right. And the sources, they start by grounding us in the definition. Diabetes mellitus, in general, is a chronic metabolic disorder defined by persistent high blood sugar or hyperglycemia. And while there are different types, this deep dive is focused specifically on type 2 diabetes mellitus,
Right.
which the material confirms is the overwhelming majority of cases.
So let's start there. What is type 2 diabetes fundamentally? What's actually going wrong in the body?
Well, the core problem, as outlined in these sources, it really revolves around how the body handles insulin. Think of insulin as the key that lets glucose, sugar from your food, get into your cells to be used for energy.
Yeah.
In type 2 diabetes, either the pancreas isn't producing quite enough of that key, or, and this is more common, the body's cells become resistant to the key.
Meaning the lock is jammed, basically.
Sort of, yeah. The sugar can't get in effectively, and often it's actually a combination of both those issues.
So it's not the same scenario as type 1 diabetes then, where the body's own immune system attacks the insulin-making cells.
Exactly. That's a key distinction the sources make. Type 1 is typically an autoimmune thing, resulting in an absolute insulin deficiency, like very little or none. Type 2, on the other hand, involves this insulin resistance and a relative lack of insulin secretion. There's still insulin there, at least initially,
Okay.
but it's either not working well or eventually the pancreas just can't produce enough to overcome that resistance and meet the body's needs.
And the scale of this is huge. How prevalent are we actually talking?
Oh, these sources highlight just how common it is. Type 2 makes up roughly 90% to 95% of all diabetes diagnoses.
Wow.
To put numbers to that, it's over 37 million people in the U.S. alone, and they estimate around 6.3% of the global population.
That's staggering.
And what's particularly striking, according to the sources, is that while it was historically called adult-onset diabetes,
Right, I remember that term.
because it usually showed up after 40 or 45, we're now seeing it diagnosed much more frequently in children, adolescents, and, younger adults too.
That shift in age is really significant. It suggests something fundamental is changing, doesn't it?
It does.
Which leads us straight to the why. If we understand what it is, this issue with insulin function leading to high blood sugar, what do these sources tell us about why it develops? What are the causes and the key risk factors?
Well, the research points to a pretty complex picture, definitely not a single cause. The fundamental mechanism often starts with that insulin resistance we mentioned.
Okay.
When your muscle, fat, and liver cells don't respond well to insulin, glucose starts to build up in the bloodstream.
And the pancreas tries to fight back.
Exactly. Its initial response is to try and power through this resistance by producing more insulin, cranking it out.
So the body tries to compensate, ramping up the insulin factory.
Precisely. But the sources explain that eventually, those insulin-producing cells in the pancreas, the beta cells, they just become unable to sustain that high level of production.
They get worn out.
Sort of, yeah. They lose function over time, and that's when blood sugar levels consistently climb up into the diabetic range.
And there's a key nuance in the sources about the timing of that beta cell problem, right? It's not necessarily just happening after years of resistance.
That's a really important update from some of the more recent research cited here. It suggests that beta cell dysfunction might actually begin earlier in the process than we previously thought, possibly even before significant insulin resistance is fully established. And they also highlight the role of excessive or inappropriate glucagon secretion.
Glucagon, that's the one that raises blood sugar.
Correct. So that adds another layer to this whole complex picture of metabolic dysregulation.
So it's not just a simple resistance then failure story.
Okay.
And genetics clearly plays a major role too. How strong is that link according to what we're seeing here?
Oh, the genetic link is quite strong, yeah. The material states that if one parent has type 2 diabetes, your risk is around 40%.
40%.
If both parents had it, that risk jumps significantly up to about 70%.
Wow.
In these big genome-wide association studies, they've really broadened our understanding. They've identified over 150 DNA variations linked to increased risk.
Over 150 variations.
Yeah, some of these variations directly impact how insulin is made or how it works, while others influence things like, body weight and where fat gets stored. They specifically mentioned the TCF7L2 gene.
TCF7L2.
Yeah, as having the strongest effect identified so far in increasing risk.
That really drives home the complexity, doesn't it? Just the sheer number of genes involved. And what about MODY? The sources mention that as a specific genetic form.
Yes, MODY, maturity onset diabetes of the young. It's actually a group of rare forms of diabetes caused by mutations in single genes.
Ah, okay. Single genes, not the 150 plus.
Right. It often shows up in younger individuals and can sometimes be misdiagnosed as type 2. It just underscores that not all diabetes that looks like T2DM, especially in younger folks, follows that typical polygenic mini-gene pathway.
Gotcha.
The sources also touch briefly on less common mitochondrial lengths, sometimes associated with specific symptoms like hearing loss.
Okay, so genetic predisposition is a major piece of the puzzle. But it feels like lifestyle is often the trigger, right? That diabetogenic lifestyle they mentioned?
Absolutely. This is where individual choices, intersect with that genetic risk. The sources heavily emphasize the link between excess caloric intake, not enough physical activity, and obesity as major drivers.
Yeah.
They note that about 90% of people with type 2 diabetes are overweight or obese.
90%.
However, they also point out, and this is interesting, that simply consuming an energy-dense diet can be an independent risk factor, even separate from overall body weight.
So not just the weight itself, but the type of food, potentially. And there was a really striking statistic about obesity's contribution, wasn't there?
There was, yeah. One source pointed out that between 2013 and 2016, obesity was responsible for a substantial 41% of new diabetes cases diagnosed in the U.S.
41% of new cases,
Yeah.
just from obesity.
Yeah, although they do note this figure varied by race and sex. But it powerfully illustrates the population-level impact of rising obesity rates on diabetes incidence.
Absolutely. Okay, so beyond genetics and lifestyle, what other risk factors or associations do the sources bring up? There's quite a list here.
Yes, the picture broadens considerably.
Right.
Other factors strongly linked to increased risk include age. The risk increases significantly after age 45,
Okay.
race and ethnicity. Certain populations, including Black, Hispanic, Native American, Asian American, and Pacific Islander individuals, have a higher risk. The sources even note variations in how risk is assessed or how glycemic markers appear across different racial groups.
Interesting.
Then there's a history of impaired glucose tolerance or impaired fasting glucose, often just called prediabetes.
Right, where the sugar is high, but not quite diabetic yet.
Exactly. Also having other conditions like hypertension, high blood pressure, or dyslipidemia, which is abnormal cholesterol and triglycerides, a history of gestational diabetes during pregnancy, or giving birth to a large baby over 9 pounds. Gestational diabetes is a strong predictor of future T2DM risk for the mother.
Yeah.
And it can impact the offspring's future risk, too.
Right.
Polycystic ovarian syndrome, PCOS, that's associated with insulin resistance.
It's okay.
There's a suggestion that low birth weight might predispose individuals to T2DM later in life. Interestingly, mental health conditions like depression and schizophrenia are linked to increased risk as well.
Really? Depression and schizophrenia?
Yep, the link is noted.
Yeah.
Also, preeclampsia and gestational hypertension during pregnancy are linked to postpartum diabetes risk.
Okay.
And one source even tentatively suggests a potential role for environmental pollutants, though that area seems to need more research.
Wow. So when you look at the full picture from these sources, it really is this complex interplay: your genetic background, your daily habits, your age, race, past medical history, maybe even factors in your environment. It's far from a single cause condition.
Absolutely. It's a multifaceted condition, really arises from the intersection of many different factors.
Given this complex origin and the fact that it often develops slowly, how do people typically discover they have type 2 diabetes? What are the signs and symptoms, and how is it actually diagnosed?
Well, the sources emphasize that one of the big challenges with type 2 diabetes is that symptoms often come on very gradually.
Sneaky.
Very.
Okay.
They can be subtle or even absent for years. This means people can have elevated blood sugar without knowing it, and, damage can be silently accumulating.
Right.
Common symptoms, when they do appear, include things like increased thirst and needing to urinate more often, feeling unusually hungry, persistent fatigue,
Okay.
cuts, or sores that are slow to heal, getting more frequent infections like yeast or fungal infections, numbness or tingling in the hands or feet, that's a sign of early nerve damage, neuropathy, blurred vision, dry skin, and sometimes unexplained weight loss.
So it can really sneak up on you.
Okay.
Are there any more acute or severe warning signs people should be aware of? Anything more sudden?
Yes, in some instances, a very high blood sugar level can trigger a dangerous acute complication called hyperosmolar hyperglycemic state, or HHS. Yeah, this is a serious medical emergency. It's characterized by severe dehydration and can present with confusion, weakness, nausea, or even lead to seizures or coma.
Wow.
And for some individuals, sadly, this can be the very first indication that they even have diabetes.
That's a critical point. So if someone experiences these symptoms or maybe just has risk factors, how is a formal diagnosis made based on these sources? What are the tests?
Diagnosis relies on specific blood tests that measure blood sugar levels.
Yeah.
The standard tests described are first, the fasting plasma glucose test, the FPG, requires an 8-hour fast. A result of 126 milligrams per deciliter or higher on 2 separate occasions is diagnostic.
2 separate tests.
Right. And there's the 2-hour oral glucose tolerance test, the OGTT. This involves drinking a specific sugary solution after fasting and then measuring blood sugar 2 hours later. A level of 200 or higher at that 2-hour mark is diagnostic.
Okay.
But the sources note this test is less commonly used for routine diagnosis these days. It's just less convenient and can have more variability.
Makes sense.
And then the third main one is the glycated hemoglobin A1C test. This is widely used because it gives you an average of blood sugar levels over the previous, say, 2 to 3 months.
Ah, the long-term view.
Exactly.
Yeah.
An A1C level of 6.5% or higher is diagnostic. It's convenient, no fasting needed, less affected by recent stress or illness compared to just a fasting glucose.
But there are downsides.
Yeah, the sources point out limitations. It's more expensive than the FPG, maybe has lower sensitivity for picking up prediabetes. Results can be affected by things like anemia or certain hemoglobin variations, and it hasn't been as extensively validated in some non-white populations as in others.
So the A1C gives you that longer-term perspective, which is helpful. And they mention a random glucose test, too, like just any time.
Yes, if someone actually comes in with the classic symptoms of high blood sugar, the increased thirst, urination, unexplained weight loss,
Right.
a random plasma glucose test result of 200 or higher is sufficient for diagnosis right then and there. No need for a second test in that case.
Ah.
But, and this is important, if someone is asymptomatic, doesn't have those obvious symptoms, the diagnosis always needs to be confirmed by repeating the test on a different day.
Got it. Confirm it.
Ah.
And who should be screened? Is there a universal recommendation? When should people get checked?
Based on the sources, screening is recommended starting at age 25 for everyone. If the initial test is normal, screening should be repeated at least every 3 years.
Okay, 45 baseline.
But if you have additional risk factors like being overweight, family history of gestational diabetes, things like that,
Yeah.
screening is recommended earlier, starting at age 40, or even sooner, depending on the specific risks and clinical judgment, and often annually in those cases.
And women with prior gestational diabetes.
Lifelong screening, at least every 3 years for them. It's a big risk factor.
Okay, so once a diagnosis is made, what does the research and clinical guidance in these sources say about managing type 2 diabetes? How is it actually treated?
The sources are absolutely crystal clear on this. The foundation, the absolute first line of treatment and ongoing management, is lifestyle modification.
Lifestyle first.
Absolutely. Focusing on diet and physical activity, even when medications are needed, these changes remain crucial. They're not optional add-ons.
So diet and exercise aren't just helpful, they're the core.
They're the core, yeah. Dietary recommendations generally focus on consuming a variety of nutritious foods, emphasizing fiber, monounsaturated fats, limiting saturated and refined carbs, especially those high in high fructose corn syrup.
Okay.
For physical activity, the recommendation is typically around 90 to 150 minutes of moderate intensity aerobic exercise per week.
Got it. And weight loss?
Weight loss is also highlighted as a critical target, especially for individuals who are overweight or obese. The sources even note that significant weight loss and consistent exercise can, in some cases, actually lead to remission of type 2 diabetes.
Remission, meaning the blood sugar goes back to normal without meds.
Exactly. It's possible for some, especially earlier on.
But for many, lifestyle isn't quite enough to get blood sugar into the target range.
That's correct. Medications are often necessary and are used in addition to, not instead of, those lifestyle changes.
Right.
The most common initial medication prescribed is metformin. It's an oral medication, relatively inexpensive, generally effective. And a major advantage noted in the sources is that when used alone, it doesn't typically cause hypoglycemia or low blood sugar.
Which is a big plus. Any downsides?
Common side effects can include gastrointestinal issues like abdominal discomfort, gas, that sort of thing.
Okay. And if metformin and lifestyle aren't sufficient, what's the next step? It seems like there's a whole range of other drug classes available.
There is indeed a wide array. The sources discuss classes like sulfonylureas, DPP-4 inhibitors, thiazolidinediones like pioglitazone, GLP-1 receptor agonists, and SGLT2 inhibitors. What's particularly interesting and something these sources spend considerable time on are those newer agents, the GLP-1RAs and SGLT2 inhibitors.
Ah, yes. These are the ones we've been hearing about a lot lately, with benefits beyond just lowering blood sugar.
Exactly. Research has shown really significant benefits from these classes, particularly for cardiovascular health and kidney protection.
How so?
Well, big studies like the MPA-REG outcome trial with empagliflozin, that's an SGLT2 inhibitor,
Okay.
and the LEADER trial with liraglutide, a GLP-1RA, demonstrated remarkable reductions in major cardiovascular events. Think heart attack, stroke, and even death from cardiovascular causes in patients who already had heart disease or were at high risk.
Wow. So reducing actual events, not just risk factors.
Exactly. And SGLT2 inhibitors have also been shown to slow the progression of diabetic kidney disease, which is huge.
So they're treating the sugar, but also actively protecting the heart and kidneys. That feels like a major shift in how we think about these medications.
It really is. It represents a move towards therapies that address the wider metabolic issues beyond just glucose control. Another advantage mentioned is that, similar to metformin, they generally don't cause hypoglycemia when used on their own.
Unlike some older meds.
Right, unlike older classes like sulfonylureas or insulin itself. However, they do have potential side effects. SGLT2 inhibitors can increase the risk of genital fungal infections and UTIs.
Okay.
And GLP-1RAs can cause nausea, sometimes vomiting, other GI problems.
Right. And what about insulin? When does that therapy typically become necessary?
Insulin therapy is often introduced as type 2 diabetes progresses over time. Despite other medications and lifestyle changes, those pancreatic beta cells might continue to lose function.
The ones making the insulin.
Correct. Eventually, they just cannot produce enough insulin to keep blood sugar controlled. Insulin can be given via injections or sometimes insulin pumps.
And the main risk there.
The primary risk associated with insulin therapy that the sources highlight is definitely hypoglycemia, low blood sugar. And they note that warning symptoms for lows can unfortunately diminish over time for some individuals, making it harder to detect.
So blood sugar is the primary target, obviously, but managing other related health issues is also a huge part of the picture. It's not just about the glucose number.
Critically important, absolutely. Because of the significantly increased risk of cardiovascular disease, managing blood pressure and cholesterol is just as vital as managing blood sugar.
What are the goals usually?
Treatment goals typically aim for an HbA1c below 7%, blood pressure generally below 130 over 85,
Okay.
with medications like ACE inhibitors or ARBs, often preferred because they offer some kidney protection too.
Right.
And aggressive lowering of LDL cholesterol, usually with statin therapy, targeting levels below 100 or even below 70 milligrams per deciliter if there's already established cardiovascular disease.
So really hitting all those risk factors hard. And monitoring. How do individuals and their healthcare teams keep track of everything day to day and long term?
Yeah, regular monitoring is essential. This involves checking blood sugar levels, either using a standard glucose meter with finger sticks,
The traditional way?
right, or using a continuous glucose monitor, a CGM, which provides real-time data and trends, shows you where things are heading.
Which seems like a game changer for many.
It can be, definitely. The choice often depends on factors like cost, insurance coverage, individual needs. But beyond the daily or frequent sugar checks, regular lab tests are needed. That includes HbA1c every few months, lipid panels to check cholesterol, and urine tests to look for albumin excretion.
Albumin?
Yeah, it's an early sign of kidney damage. Catching it early is key.
Okay. We've covered what it is, why it happens, how to find it, and how it's treated. Now, looking ahead, these sources emphasize that type 2 diabetes is a chronic condition. What does that really mean for the long term? What are the potential complications everyone's trying to avoid?
That's the critical part of understanding why management is so important. Type 2 diabetes is considered a lifelong condition. There's no known cure outlined in these sources.
Right. Management, not cure.
Exactly. Effective management controls the blood sugar and reduces the risk of complications, but the underlying issue, well, it persists.
And the reason control matters so much is because persistently high blood sugar, probably coupled with that high blood pressure and cholesterol often seen with P2DM, can damage almost every organ system over time.
Precisely. That chronic damage leads to a range of serious, potentially disabling, and life-threatening complications.
Yeah.
The sources break them down into two main categories.
Okay.
First, microvascular complications. This is damage to the small blood vessels.
Micro, small. Got it.
Right. This includes retinopathy, affecting the eyes. It's a leading cause of blindness. Nephropathy, damaging the kidneys, the leading cause of end-stage renal disease requiring dialysis or transplant.
Wow.
And neuropathy, affecting the nerves. This causes that pain, numbness, or tingling, but can also impact internal functions like digestion, sexual function, or bladder control.
So eyes, kidneys, nerves. And the second category.
Macrovascular complications.
Yeah.
Damage to the large blood vessels.
Macro large.
This leads to cardiovascular diseases, which the sources consistently identify as the leading cause of death for people with type 2 diabetes.
The #1 killer.
Yeah. This includes coronary artery disease, peripheral artery disease, cerebrovascular disease, basically significantly increasing the risk of heart attack and stroke. The risk of these events is cited as being 2 to 4 times higher in people with diabetes.
2 to 4 times.
And approximately 2/3 of individuals with diabetes ultimately die from heart disease or stroke, according to these sources.
That's incredibly sobering. So the macrovascular issues, the heart and circulation stuff, are the biggest killers. And they potentially start earlier. Something about a ticking clock.
Yes, that concept is mentioned. The idea that macrovascular risk might begin accumulating earlier in the disease process, possibly tied more directly to the underlying insulin resistance and related metabolic issues, while microvascular complications seem more tightly linked to the duration and severity of the high blood sugar itself.
Interesting distinction.
And they also include an important point, questioning that historical view that having T2DM is automatically equivalent to having already had a heart attack in terms of predicting future cardiovascular risk. Yeah, noting some studies found lower long-term cardiovascular event rates in T2DM patients without prior CV events compared to those non-diabetic patients who had already had one. So it's maybe not a perfect equivalence.
Okay, that nuance is important. What are some of the other complications the sources mention beyond the eyes, kidneys, nerves, and heart?
Other significant issues include foot problems. These are a major concern due to the combination of neuropathy, losing feeling, and poor circulation.
Right.
This increases the risk of ulcers, infections, and, tragically, makes diabetes the leading cause of non-traumatic lower limb amputations. Links are also noted to skin conditions, gum disease, hearing loss, gastrointestinal issues, sexual dysfunction, and even an increased risk of certain cancers, like bladder cancer. Though, interestingly, one mention of better survival with metformin in some cancers.
How much does achieving tight blood sugar control actually impact the risk of all these complications? Does getting the A1C really low fix everything?
Well, tight blood sugar control, particularly when it's initiated earlier in the disease, is definitely shown to significantly reduce the risk and slow the progression of those microvascular complications, the eye and kidney damage especially. Studies like the big UKPDS trial provide strong evidence for this.
Okay, so clear benefit for the small vessels. What about the big ones, the macrovascular?
For macrovascular outcomes, the picture is a bit more complex based on the sources. While managing blood sugar is absolutely part of reducing overall CV risk, very intensive glucose-lowering strategies.
Like pushing the A1C super low.
Exactly, especially in older patients who already have established disease and existing cardiovascular issues. Those strategies haven't always shown the same clear reduction in macrovascular events like heart attacks or strokes.
Why not?
Well, in some cases, it actually increased the risk of severe hypoglycemia, which can be dangerous in itself, especially for someone with heart problems.
So for individuals later in the disease course or with other health issues, just pushing sugar really low might not provide the same payoff for heart health as it does for the smaller vessels, and could even introduce risk.
That seems to be a key takeaway from some of the later trials mentioned, like Advance and Accord, when you compare them to earlier studies like UKPDS.
Okay.
The sources really emphasize that the most beneficial strategy for long-term outcomes, reducing both micro and macrovascular complications, seems to be early, intensive, and multifactorial management.
Multifactorial meaning?
Meaning aggressively addressing blood sugar and blood pressure and cholesterol combined with those crucial lifestyle changes. Right from the start, ideally. Studies like the Steno-2 trial really demonstrated the power of that comprehensive approach.
Got it. So it's the whole package.
Exactly. The overall prognosis really hinges on how comprehensively and consistently the condition is managed over the long haul.
Managing all of that diet, exercise, medications, monitoring, multiple risk factors, potential complications. I mean, it sounds like a tremendous amount of work and requires constant attention. How do these sources describe the reality of living with and managing type 2 diabetes day to day?
They definitely stress that it is complex and requires ongoing daily effort and decision-making. It's really framed as a team effort.
Not just the individual.
Right. It involves the individual, absolutely, but also their healthcare team doctors, certified diabetes educators, dietitians, specialists like eye doctors or podiatrists, and also really important is support from family and friends.
So patient education isn't just a one-off pamphlet you get at diagnosis. It's got to be an ongoing process.
Crucially so. The sources highlight that patient education is absolutely vital and needs to be an active, continuous process. They note that while initial individual education might be particularly helpful for those struggling with control early on, ongoing education is valuable at all stages of the condition. And often, non-physician healthcare professionals, like those certified diabetes educators, play a key role in providing that practical, ongoing support and coaching.
Based on the material, what are some practical tips or aspects of daily living that come up for someone managing T2DM?
Well, consistency seems key, starting with those fundamental lifestyle changes, and the sources suggest starting small can help build momentum, not trying to overhaul everything at once.
Makes sense.
Regular blood sugar monitoring is important to understand how diet, exercise, medication are affecting levels day to day.
Right.
Taking medications exactly as prescribed, that's non-negotiable.
Right.
Regular visits with a healthcare team are essential. And importantly, seeing an eye doctor at least yearly to screen for retinopathy is critical, even if vision feels perfectly fine.
Don't wait for symptoms.
Exactly. Having a sick day plan, knowing how to manage blood sugar during illness when things can get thrown off is also advised. Staying informed, asking questions, seeking out reliable resources, that's important too.
And mental health.
Yes, given the increased risk of depression and anxiety that was mentioned, taking care of mental health is also highlighted as a vital part of managing the condition overall. Finding community support can also be really helpful.
And when should someone managing T2DM reach out to their doctor or healthcare team outside of routine appointments? When do you make that call?
The sources suggest calling immediately if experiencing issues like persistent vomiting or diarrhea, especially if it's hard to stay hydrated, or if blood sugar levels are significantly outside their target range, particularly if very high or very low and not responding to usual measures, or of course if they experience symptoms of severe hypoglycemia.
Okay, good to know.
So as we wrap up this deep dive, we've seen that type 2 diabetes is, well, it's a complex chronic metabolic disorder. It's characterized by those issues with insulin function leading to high blood sugar, driven by that mix of genetic predispositions and lifestyle factors we talked about.
Diagnosis relies on specific blood tests. We covered those. And management is definitely multifaceted, built on lifestyle changes, often requiring medications, including some of these newer ones that offer significant benefits beyond just lowering sugar, particularly for the heart and kidneys.
And while it's a lifelong condition requiring proactive management and very much a team approach, understanding the potential complications and diligently working to manage not just blood sugar, but also blood pressure and cholesterol, that can dramatically improve long-term health and reduce the risk of those serious outcomes.
Right. This deep dive was really about trying to bring you those essential insights from the source material without getting totally lost in the weeds. It's clear that managing type 2 diabetes effectively is a challenge, no doubt about it. But with consistent effort, education, and support, it seems absolutely possible to mitigate the risks and live a healthier life.
And that leads to maybe a final thought to consider, drawing from these sources. Given this emerging understanding that beta cell dysfunction might start earlier than we perhaps thought, and the documented links between type 2 diabetes and factors like socioeconomic status, mental health conditions, specific genetic variations, how does that perspective maybe reshape the idea of type 2 diabetes being solely a lifestyle disease?
That's a good question.
Does it push us to think more broadly about prevention, about public health interventions, about the interplay between biology and society?
Plenty to think about there, definitely. And just a final reminder, of course, this deep dive provided general information based on the sources we had. Always consult with qualified healthcare professionals for personalized medical advice regarding your own specific situation.